So I'll hand over the session to the organizers back for the next session, please.
Thank you for your kind understanding, sir. And with that, we will move on to the next session for today. And to take that forward, may I please request our respected chairpersons and panelists, Dr. Soumitra Kumar, Dr. Dipankar Dotto, Dr. Abhijit Bhattacharya, and Dr. K.N. Siddiqui to join the session. We have Dr. Debasish Banerjee from UK with us as the speaker for the next session, and he will talk on management of patients with chronic kidney disease and heart failure. Before I welcome Dr. Debasish Banerjee to deliver his talk, it is my proud privilege to introduce him. Professor Banerjee is a nephrologist with a special interest in cardiovascular complications of chronic kidney disease. He is the quality lead for MBBS program and joint head of the section of clinical teachers in St. George's University, London. He is also the co-director of the Translational and Clinical Sciences Research Institute at St. George's University of London. He works on various roles for the International Society of Nephrology, European Society of Cardiology, and UK Kidney Association. He established the multidisciplinary CKD heart failure clinic in St. George's Hospital. His research is on vascular and cardiac changes in CKD, the risk factors, and the intervention with randomized controlled trials. Over to Dr. Debasish Banerjee to present his talk.
Thank you very much. How do I share my slides?
There is a share screen option. Please go to that. It's the usual Zoom sharing.
Thank you very much. I think I've got it now.
Is it working? Yeah, we can see.
Probably you can see my screen.
Yeah, your screen is becoming visible. Yeah, that's it. And please make it full screen. So very good afternoon from Kolkata, Dr. Banerjee, your city of origin.
Thank you. Thank you very much. No, I'm actually delighted to be here. And also I wanted to thank the organizers, particularly that kind introduction that you gave, and also Subro in particular, who actually invited me in the beginning. I'm actually a kidney doctor, so I'm going to be talking to a lot of cardiologists I know. But I want to keep things simple and more kidney-centric during the next 20 minutes or so. I'm going to talk about management of patients with chronic kidney disease and heart failure. Let me start by sharing one of my patients' histories here with you. He's a gentleman I actually saw day before yesterday in the clinic. He's an 84-year-old gentleman, lived with his wife, quite independent, walks his dog every morning. And interestingly, he hasn't had any hospital admissions 2 years prior to seeing me. And now that I've known him for 2 years, he hasn't had any hospital admissions. So he's doing pretty well. When I saw him, his blood pressure was 100/60, slightly low. Pulse rate was 62 because he was on a beta blocker. His potassium was 5.2, GFR was 30. So he was CKD stage 3B, going on to CKD stage 4. His hemoglobin was 114, but ferritin was low, so we gave him some intravenous iron in our clinic. Just to mention about the clinic, so every Thursday at St. George's Hospital, we have a combined heart kidney clinic with the anemia nurse in the clinic. So we were very lucky and we could give him the intravenous iron on the same day. And the question is, in this gentleman, as you can see on the left-hand side, with multiple comorbidities, including diabetes, ischemic heart disease, etc., and heart failure with reduced ejection fraction. And when he came to us, he was not on the entire guideline-based medical therapy, which I'm sure you have been talking a lot about. So in the clinic, we were able to introduce an SGLT2 inhibitors, as you can see in your bottom right, dapagliflozin. And we also introduced sacubitril valsartan and maximized the dose, and eplerenone. We were very lucky we could enroll him in the LIFT study, which is one of the studies that we are organizing at St. George's. And with the help of close monitoring, so we used to see him every 2 weeks when we introduced these new medications for guideline-based heart failure therapy. and we were able to maximize the dose. And I'm very proud to say, over the last 2 years, he hasn't had any hospital admissions. Here's a few facts about CKD in heart failure. Firstly, it's quite common. Secondly, it's often in patients who are elderly and frail, like the gentleman I spoke about. The other interesting thing is that these patients have higher hospitalization rates and higher mortality. I'm sure you are all aware that they have hyperkalemia and they have more changes in GFR when you introduce guideline-based medical therapy. One of the corollaries is that these patients do require monitoring and hence utilizes higher healthcare resources, they get more hospital admissions. And the other thing to remember is that having CKD and heart failure impacts the function of the other organ adversely. Now, one of the things that I would like to emphasize is our chronic kidney disease heat map introduced by KDIGO a few years ago. And you can see here, what I'm trying to show you is not only the kidney function, but also presence of albuminuria indicates the risk, cardiovascular risk. So you can see as the proteinuria on your top goes from less than 30 milligrams per grams to more than 300, the risk, which is shown in this traffic light system, increases from green to red. And obviously the same thing happens with declining GFR. As you can see on your left, more than 90 to less than 15, the risk increases. Please keep this in mind. How common is chronic kidney disease in heart failure patients? I would say it's very common. If you look on the left-hand side, this is a meta-analysis by Dr. Damon on 57 studies, including registry studies. You can see that the risk of chronic kidney disease in these patients is quite high, 50%. The other thing to remember is that when you start the new medications, one thing which happens is a worsening of kidney function. We call it worsening of renal function. And that happens in 25%. So half the patients have CKD and quarter of the patients have worsening renal function when you start guideline-based medical therapy. We have seen the same thing in our clinic. So you can see in your bottom right, this is work by one of my previous research students, Dr. Rebecca Jenkins, and you can see that prevalence of CKD in admitted heart failure patients in St. George's is quite high, once again, 47%. This is an interesting slide from Nisha Bansal. When she analyzed data from 3,700 patients, followed up over a long period of time, looking at how does kidney function and urine albumin impact on the risk of hospitalization. And you can see in this slide, as the GFR goes from 45 to 70 on your left to less than 30, the risk of hospitalization goes from 3.1 to 10.3. But what is very interesting is that when you look on your right, with the increasing ACR from less than 30 to more than 300, the hospitalization risk goes from 2.9 to 9.7. And this is adjusted for a lot of things. So again, kidney function and urine albumin are both indicators of risk. Now, one of the interesting things, and this is analysis by Dr. Javed Butler, who I think will be in your meeting later on during the day, that when he looked at the 9,700 patients from the EMPEROR reduced and preserved, so large population across the range of GFR and across the range of ejection fraction, you can see the risk, which is low on your left-hand side, is associated with event rate, which is high, but not as high as the ones which are in red, where the event rate is 20, which is 3 times higher than the low-risk patients. So this is following the KDIGO risk on your left-hand side. And you can see the risk reduction, interestingly, is quite remarkable, going from minus 1.2 to minus 2.8. So the risk increases with the KDIGO categories, and the risk reduction increases with the KDIGO categories. So these patients do get benefit. This is a slide I have prepared for you to have a glimpse of all the studies that have been published recently on SGLT2s, on sacubitril valsartan, on omecamtiv, and on and if you look at what kind of patients were included in these studies, so these are large heart failure studies, starting from DAPA heart failure on your top left. They go down to a GFR of around 20 in some of the studies, but at least up to 30, to at least up to CKD stage 3B in most of the studies. And when you compare the effect on GFR, patients with a GFR of less than 60, which is in the middle, so this is CKD stage 3B and above, you can see the risk reduction is similar, if not more. So if you look at the DELIVER study, which is on the second column of the studies, you can see the risk reduction is 0.81 and EMPEROR preserved is 0.78, compared to the patients who are more than 60, where it is risk reduction ratio is 0.81. So you get a better risk reduction. Same is true for soloist heart failure. So here you've got evidence that in patients with chronic kidney disease, at least 3B, the risk reduction is similar or sometimes more. So we have evidence. Now, how are we doing? Not very good in prescribing guideline-based medical therapy in heart failure patients with reduced ejection fraction. And this is a very large analysis of the Swedish heart failure registry by Dr. Janse et al., 31,000 patients. And from your left to right, you're going from a GFR more than 60 to less than 30. But let me just attract your attention to the one that I've highlighted in red. This is CKD stage 3B. And in the previous two slides, I've shown you that there is evidence. But look at the triple therapy prescription. It's 28%. And the initiation by, i.e. filling the prescription, 19%. So 19% of the patients are actually having these medicines, which they should be on. Now, one of the interesting things in this particular slide is that the age of the population. So CKD stage 3B have an age of 80 as opposed to 74 when the GFR is more than 60. So these are slightly older patients. How about when we discharge these patients after an acute heart failure admission? How are we with triple therapy? And this is data from the ADHERE registry data, which is a database from an audit in the United States, 157,000 patients. And if you just concentrate on the top, the data table, with a bit in which is in red, and that's CKD stage 3B, you can see triple therapy initiation is in 15%, 1-5. And the mortality is 3, and the adjusted mortality, which is in the figure in the middle, in CKD stage 3B is at least 2 times higher. So you've got high mortality, and we don't give the medicines that we need to give. This mortality is in hospital mortality. So we're not doing very well. And I put those two studies in this slide. Top left is a Swedish study. 19% of the patients in CKD stage 3B are on GDMT. On the right is the American study, 15%. And at the bottom is our own study from St. George's Acute Hospital Admissions. This is 2015 data, 12%. So we are doing poorly across the different countries. Now, you might be worried about frailty and old age in patients with CKD who have heart failure. And that's true. This is data from our own CKD clinic on 103 patients, our own CKD heart failure clinic by Dr. Tumulty, one of our academic fellows. And you can see here, frailty is quite common. It's present in 49% of the patients. It was associated with polypharmacy. It was associated with increased pain, decreased physical functioning, decreased energy levels, decreased social functioning. And when you ask them what they want better quality of life and avoid hospital admissions. So these patients are frail, but they are looking for better quality of life and avoiding hospital admissions. So, do we have evidence in CKD patients who can be often old and frail? And here it is. This is Dr. Jawad Butt, analysis of the DAPA heart failure study. And what he was looking at is what happens with increasing frailty. So from left to right, you're going from not frail patients with a frailty index of less than 0.2 to most frail patients, which is a frailty index of 0.31. And if you just look at the things which I've highlighted either in bold or in red, you can see from not frail to most frail, the GFR declines from 73 to 53. So most frail patients have a lower GFR. When you look at the proportionate of patients with GFR of less than 60, it goes from 24% in not frail patients to 71% in most frail. So these patients are, the most frail patients have a lower GFR, higher proportion of CKD patients. But you can see when you look at the risk reduction of worsening heart failure or cardiovascular death, it's exactly the same. 0.71 there as opposed to 0.72. So this tells you that CKD patients might be slightly older. Here you can see the age is 70 as opposed to 63 and more frailer, but they get the same benefit. This is DELIVER study across the range of ejection fraction. You can see the same story here. GFR from not frail to most frail goes from 69 to 52. Proportionate of CKD patients from not frail to most frail goes from 30% to 72%. But look at the risk reduction, 0.74. So a better risk reduction. And the same is true for Entresto. Without going through the details in this particular slide, you can see the proportionate of CKD patients goes from 11 to 62%, and the risk reduction goes from 0.98 to 0.69. So you get a better risk reduction in these patients. Because remember, the risk is higher in these patients, so the risk reduction is higher as well. This slide I put together for you, trying to summarize where is the evidence. Good quality evidence in dark green. You can see up to a GFR of 30, you got very good evidence with beta blockers, ACE inhibitors, MRA, SGLT2, ARNI, vericiguat, and omecamtiv mecarbil. So you can see there is very good evidence up to CKD stage 3B. Below that, the evidence varies. You know, when there is some evidence, I put it in light green, and where there is no evidence, I put it in dark green. So remember, there is some evidence at least up to CKD stage 3B, actually good evidence. One of the problems we have in our CKD patients, and that's coming from a kidney doctor, is that there is a lot of admissions, emergency admissions, which are potentially reversible, and this is data from Canadian registry, are due to either heart failure or hyperkalemia. So these are the problems we as kidney doctors deal day in and day out. Now, how common is high potassium? Now, this is a very busy slide. I don't want you to go through this entire slide. This was prepared by one of my academic fellows, Dr. Dan Murphy. But what I'm trying to emphasize here, so for example, if you look at the FIDELO-DKD study where you used finerenone on top of 99% of the patients on ACE on ARB, yes, you get hyperkalemia, 22%, but it's manageable. So the discontinuation rates of finerenone was very low in FIDELO-DKD study. And we have toolkits. Now, I wanted to kind of advertise this toolkit, which the International Society of Nephrology, together with the European Society of Cardiology and American Society of Preventive Cardiology, has prepared. And it's on the web. You can all use it. The link is at the bottom in the International Society of Nephrology website. And you can see they have clear messages or clear, it's a toolkit on how to use these RAS inhibitors when you have a potassium of 5 to 5.5, more than 5.5, but less than 6 and more than 6. And you can use potassium binder. On your right-hand side, again, Dr. Butler, last year, showing that you can maintain low potassium for 52 weeks. The other problem is the declining GFR. Now, without going into the details of this slide, I will try to emphasize that with SGLT2, as you can see on your right, there is a decline in GFR as soon as you start, but actually it helps in the long run. And same with ACE inhibitors at the bottom. The mechanisms are different. One is tuberoglomerular feedback and one is RAS inhibition. But we call it permissive AKI and we let it happen because we know the benefits in the long run outweighs the problem that we see in the beginning. And again, you have this nice toolkit on the ISN website. You can see with collaboration with the heart failure associations. It's very, very useful. Please do use it. Intravenous iron can be quite useful, particularly in symptomatic patients. And this is data from the AFFIRM AHF study, acute heart failure study. You can see intravenous iron is associated with lower hospitalization rates. But as you all know, last week with the HeartFeed study, we have seen that it probably doesn't benefit all patients who are asymptomatic. That's published in New England Journal a couple of weeks ago. This is an interesting slide. I really like this. It's Dr. Gregory Moss-Filipatos looking at the finerenone studies showing that incident heart failure is prevented with finerenone. You can see, and a lot of these patients had low GFR. This is also very interesting. You are probably all aware of it. It's the use of high-intensity therapy in acute heart failure patients, maximizing the medication and looking at the effects by day 90. You're all aware that it decreased the increased the event-free survival. But what I would like to concentrate your attention to is the bottom right. You can see that the patients who had a median GFR, a GFR which is lower than the median, the benefit was more. But it does require multidisciplinary care. This is our clinic, 124 patients, followed up for 234 days. You can see you can increase dual RAS therapy, correct iron deficiency. So you can do it, but you have to do it together. This is kidney heart doctors with an anemia nurse. But they have a lot of hospital admissions. As you can see here, same clinic, 667 admissions over a period of 443 person years in 318 patients. This is eye-watering. But you can do something about it, provided you follow the European Society of Cardiology guidelines, which are not guidelines, recommendations on the right-hand side, how you can increase these therapy in all levels of GFR. And this is published in the European Journal of Heart Failure by Dr. Mullins. But the patient needs to be at the center, as you can see on the left-hand side. So what have I told you? I've told you there is evidence. Hyperkalemia and GFR changes do happen. Dose escalation is possible, but better done in multidisciplinary care. Personalized care is important. Heart failure therapy is preventable. That's quite exciting for us. And intravenous iron can be used. These are the people who have helped me over the years to collect some of the data, and that's an advertisement for the International Society of Nephrology Toolkit once again. Thank you very much.
Thank you, Dr. Banerjee, for your very insightful talk. We learned a lot from it.